Hello, I'm Dr. Marty Ross. In this video, I'm talking about mold toxin illness and what you can do to combat this issue. I describe how to diagnose it. I describe what binders to use to actually remove mold toxins. And I also describe when it might be appropriate to actually try to kill mold that might even be living in your sinuses or in your intestinal tract that actually is producing some of those toxins. So take a look at the whole video. If you need more information, below the description of this video is a link to a full written article that I have about mold toxicity illness and Lyme disease. Treat Lyme is supported by purchases you make through Marty Ross MD supplements. There's a physician named Richie Shoemaker who is the pioneer of the issues of mold toxicity in Lyme and not in Lyme, okay? And then some of his work has been replaced and I think greatly improved by more recent work that's been done by a physician named Joe Brewer, who's an infectious disease doctor in Kansas. All right, so I'm going to talk about both of them to answer your question. So what Shoemaker was able to show is in all people, not just Lyme patients, okay, but in all people, 25% of us have a genetic programming issue where we're not able to remove mold toxins once they get into us, okay? And that's based on Shoemaker's work, all right? And Shoemaker has a genetic profile test called an HLA-DR test that you can do to see if you might be susceptible to this problem. But the reality is, I don't find his test to always be an accurate predictor, and I don't do it. I think it's a waste of money. It's about a $1,200 test. It's a waste of money, okay? But according to Shoemaker's work, 25% of us have this problem. And what's supposed to happen in 75% of us is the immune system will see a mold toxin once we breathe it in or drink it in, and we'll tag it for removal, and it gets broken down and gets removed from the body. Okay, that's what's supposed to happen to 75% of us. In 25% of us, though, what happens is those mold toxins don't get tagged. They go to the liver as a fat-based toxin. Now, the liver is supposed to change things that are fat-based into a water-based form, where they then get moved out in the intestines, they mix in our poop, and we poop them out. Okay, that's what the liver is supposed to do. But with mold toxins, it can't do it. And it takes those mold toxins, and they go to the liver fat-based, they come out fat-based, they go into the intestines, and things that are fat-based in the intestines get reabsorbed back into the bloodstream. So you get this mold that just keeps, mold toxins that just keep recirculating, all right? All right, so mold toxicity can look a lot like Lyme disease. In fact, they can look kind of identical at times, all right? And here's why. So as many of you know, when somebody has Lyme disease, I say it's a syndrome of too many cytokines, right? I mentioned that earlier tonight. When you have Lyme, the immune system sees Lyme, and white blood cells, to get rid of Lyme, make a group of inflammation chemicals called cytokines. And they're good, they turn the immune system on, but Lyme doesn't do a good job, or immune system doesn't do a good job of getting rid of Lyme often. And the immune system tries harder and harder, and eventually it makes too many cytokines. And too many cytokines give you most of what we call Lyme symptoms, okay? They make it so you can't think, they make it so you can't sleep, they make you hurt all over, they give muscle wasting, they give you weakness, etc. All those Lyme symptoms are really too many cytokine symptoms, okay? Now, when you have toxins circulating in you, the immune system sees them and also makes cytokines. So guess what? Mold toxicity can look identical to cytokine issues, okay? And because 25% of people out there, whether they have Lyme or not, are genetically programmed in a way they can't remove mold toxins, that means that probably 25% of people with Lyme also have the same problem, all right? All right, so Shoemaker would say we should all do his genetic test, this HLA-DR test. But what I have found is even when it suggests that somebody might have a mold toxicity problem, if you give them the things to bind up the mold toxins, often they don't get better. So it means his test is not correctly identifying them. Also, if you have people that his testing says don't have the problem, often if you give them the mold binders, they're still going to get better, okay? All right, so what does Shoemaker use? Well, Shoemaker likes to use something called cholestyramine, which is a anti-cholesterol medicine. It binds cholesterol. And that's what he suggests, that you actually do a scoop of this 3 times a day. Now, I got to tell you, or 4 times, 3 to 4 times a day. In Lyme,
when you've got somebody with Lyme disease and mold toxicity, if you try to do 3 scoops a day of cholestyramine right away, you're going to get clobbered. All right. Shoemaker does not take care of the same kind of patients I take care of. All right. You can't do it. What happens is if you start the cholestyramine too quickly, pulling those toxins out triggers a cytokine flare, which can look like a Herxheimer reaction, okay, but it's a cytokine flare. You can get clobbered. So if I am going to do cholestyramine, if I've got somebody that I'm trying to see, could they have this problem? And they've got a history of a lot of mold exposures in their background. They've lived in a building they know had mold in it. What I will do often is not do Shoemaker's genetic testing, but rather I will just do a trial of cholestyramine. And I will do it at 1 scoop 3 times a day. But I build up to it. I start often at 1 scoop 1 time a day. And if they're not reacting to it after a week, I mean, if they're not flared up by it, then I may go to 1 scoop 2 times a day. And after another week, I may go to 1 scoop 3 times a day. All right. When you use cholestyramine, you got to make sure that you take it away from, you have to take it away from medicine. So you have to stop all your medicine and supplements 30 minutes before you take it, and then you resume taking them up to 2 hours later. The ideal time to eat is a half hour after you take the cholestyramine, okay? So that's cholestyramine, all right? Now, then we got Joe Brewer. And Brewer has been able to show, Dr. Joe Brewer has now been able to show, working with a lab out of Texas called Real Time Labs, we now have a way to measure whether what toxins you actually have in you, okay? And Real Times has the ability to look to see if you have 4 different kinds of toxins. One is called trichosethine, which is black mold toxin, something called aflatoxin, something called ochratoxin, and something called gliotoxin. Now, gliotoxin, I want to let you know, does not only come from wet buildings, it can come from too many yeast living in you as well, too, all right? All right. Now, Brewer has done a lot of his work based on using real-time labs. And what Brewer has been able to show is that when people have chronic fatigue syndrome, not Lyme, but chronic fatigue syndrome, about 80 to 85% of them also have mold toxicity issues. It's pretty profound, actually, okay? And so what you can do with the real-time labs is you can actually document, does somebody pee out mold toxins? And if they do, then after you do your binders, then you can go back again and retest them to see if they're gone. Pretty good stuff, okay? Now, the problem with the real-time labs test, though, is it's ridiculously expensive. It's $795, okay, for the first test. Now, if you're going to do repeat testing, and I'll do that, and I think a repeat test is $195. So once you're in their system, you can get repeat testing done, okay? Now, why would you even want to do the real-time lab? So often I am going to do just a cholestyramine trial. But more recently, Brewer has been looking at the literature and looking at what binders work best for which toxins, okay? And cholestyramine may not always be the best binder. So for instance, charcoal may do a better job at binding trichosethine than what cholestyramine does, for instance, okay? And gliotoxin may be better bound by bentonite clay, for instance, okay? So it all depends on what you pee out as to what the best binder is going to be. I still tend to work a lot more with cholestyramine. I think it's a better universal binder. But if I'm working with somebody, I'm using cholestyramine, and I go back and retest, and their toxins aren't dropping, I'm going to start tailoring my binder based on what the toxin is that they actually pee out, okay? And I always have to look at my chart, so I'm not going to be able to give it to you directly off the top of my head. But depending on that toxin profile, and one of these days I will update, actually probably within the next week or two, I will update my mold toxicity article and include in there a table that will show you, depending on the toxin you pee out, what is the best binder to use, okay? So I will be doing an update. I'll probably use this as a video clip tonight to talk about where the science has gone, okay? All right, the last thing is, even if you're using the right binder and you are still peeing out toxins, Brewer then has shown that some of us become colonized with our mold. That's not a good thing. What that means is that when you become colonized, is that the mold can live in the mucus of your sinuses, or it can live in the lining of your gut, and it may from there then keep releasing toxins. So generally what I'm going to do, if I think I've got somebody with a possibility of mold toxicity issues, I'm going to, based on their history, I'm going to first try a trial of cholestyramine. And if they get better, great. If they don't, then I'm going to wind up doing one of these real-time lab studies to see, are they really peeing the stuff out, okay? And if they are, then I'm going to tailor my anti-mold agent based on, or anti-mold toxin agent based on what they're actually peeing out. And if they still remain sick after binding for another month or two, then I may start actually giving them killers to kill the mold toxins. And those can be nystatin nose spray, itraconazole nose spray, amphotericin nose spray, a couple times a day on both of those. Or, and you need to combine it with something to kill yeast in the gut, which would be something called itraconazole. Okay, so this gets to be a really complex issue.